Fibromyalgia affects approximately 2.7% of the global population. For those diagnosed, the economic toll is severe, with healthcare expenditures reaching $35,920 per patient annually. To treat this condition, the FDA has approved exactly 3 medications: the anticonvulsant pregabalin and 2 antidepressants, duloxetine and milnacipran. Yet clinical data reveals a frustrating reality. Despite passing regulatory hurdles, the long-term efficacy of these drugs remains deeply unsatisfactory for most patients. This graph maps patient adherence over 12 months. By year's end, compliance falls off a cliff, with over half abandoning treatment. The discontinuation rates are stark: 64.6% for pregabalin, 51.5% for duloxetine, and 72.1% for milnacipran. To understand this massive failure rate, we have to look at the etiology. Fibromyalgia is a central sensitization syndrome, a pain regulation disorder driven by a complex mix of genetic, hormonal, and immunological factors. This translates into a profound heterogeneity of symptoms. Patients experience chronic widespread pain to severe cognitive dysfunction, known as fibrofog. Attempting to manage this massive variance by targeting a single pathway is inherently flawed. We need to evaluate the randomized controlled trial data to see where these drugs fail mechanistically, and then examine the emerging Phase 3 pipeline to see what comes next. The current pharmacological standard of care statistically fails the majority of patients. This demands a critical reevaluation of exactly how we approach central sensitization. Duloxetine and milnacipran belong to a class of drugs known as serotonin and norepinephrine reuptake inhibitors, or SNRIs. Their clinical goal is to enhance central pain regulation. This schematic of a synaptic cleft shows how they work. By inhibiting the presynaptic reuptake of serotonin and norepinephrine, these drugs artificially elevate the levels of these neurotransmitters within the central nervous system. But the clinical outcomes hit a hard ceiling. At doses of 60 to 120 milligrams per day, duloxetine achieves a statistically significant 30% reduction in pain, but only for roughly 30% of the patient population. The number needed to treat highlights this limitation. To achieve a 50% or greater reduction in pain, you must treat 8 patients to see that benefit in exactly 1. Milnacipran presents a slightly different profile. Among the approved drugs, it shows a distinct statistical superiority in treating the severe fatigue associated with fibromyalgia. However, this comes with an 86% incidence rate of adverse events. Patients frequently endure severe nausea and persistent headaches. Milnacipran also carries a severe clinical limitation, a black box warning, due to an increased risk of suicide in children, adolescents, and young adults, effectively removing it as an option for younger demographics. These inescapable adverse event profiles inevitably suppress long-term adherence. Patients simply cannot tolerate the side effects long enough to maintain SNRI monotherapy. Pregabalin approaches the nervous system on a completely distinct neurochemical axis. It is an anticonvulsant and a GABA analog. We can see its precise target in this vector model of a voltage-gated calcium channel. Pregabalin binds directly to the alpha-2 delta subunit to modulate neural signaling. This binding successfully reduces the influx of calcium ions, which in turn blunts the release of excitatory neurotransmitters like glutamate and substance P. Meta-analysis data shows that at optimal doses, approximately 27% of patients achieve a meaningful reduction in pain. But pregabalin faces a massive tolerability crisis. The overall adverse event rate for this drug sits at an unsustainable 85% to 90%. Because it suppresses central nervous system activity, the side effects are severe. Patients experience persistent dizziness, profound somnolence, and significant weight gain. This intense physical toll draws a direct causal line to pregabalin's staggering 64.6% discontinuation rate within the first 12 months of use. Clinicians are forced into a difficult position. They must make highly flexible, patient-specific dosing adjustments simply to keep patients compliant with the drug, often sacrificing pain control to manage the side effects. Targeting central calcium channels creates an inescapable clinical trade-off. Achieving a dose high enough to block pain inevitably causes intolerable suppression of the nervous system. Faced with the high failure rates of these FDA-approved options, clinical practice is actively pivoting toward off-label alternatives to manage symptoms. Amitriptyline, an older tricyclic antidepressant, demonstrates a specific statistical superiority in improving sleep architecture and fatigue, achieving an overall clinical acceptability similar to a placebo. Another emerging option is TNX-102SL, a sublingual formulation of the centrally acting muscle relaxant cyclobenzaprine, which is currently advancing through phase 3 clinical trials. Cyclobenzaprine antagonizes 5-HT2A and H1 receptors. This improves restorative sleep and reduces motor neuron excitability, avoiding the severe adverse profiles associated with gabapentinoids. Beyond off-label uses, the novel pharmacological pipeline is shifting away from traditional central nervous system modulation. Researchers are searching for completely new receptor targets. One new class includes N-methyl D-aspartate, or NMDA, receptor modulators, featuring investigational drugs like NYX-2925 and memantine. By modifying glutamate signaling through NMDA antagonism, these drugs protect neuronal cells and blunt persistent pain without inducing the classic side effects seen with SNRIs. This schematic compares a traditional central nervous system target with a peripheral nervous system target, the KCA 3.1 channel. A primary example of this new pharmacological philosophy is ASP-0819, a novel non-opioid channel opener. ASP-0819 works by reversing abnormal sensory neuron discharges specifically in the peripheral nervous system. This bypasses central suppression entirely. The future of fibromyalgia pharmacotherapy depends on this transition. Medicine must move away from blunt central nervous system suppression toward highly precise peripheral targeting. Bringing this back to the overarching clinical reality established by the meta-analytical data, a clear picture emerges regarding the current standard of care. Look at this aggregated treatment matrix. The adverse event profiles are the primary structural barrier to treatment success across the board. Currently approved pharmacological agents provide meaningful, sustained relief to only about 30% of patients. The immense heterogeneity of fibromyalgia's clinical presentation, affecting sleep, mood, pain, and cognition, guarantees the absolute failure of any single-target pharmacological monotherapy. Because of this, until emerging mechanisms establish long-term safety and efficacy, current clinical guidelines restrict pharmacotherapy to a strictly adjunctive role. The foundational strategies for managing this condition must be non-pharmacological. This includes patient education, cognitive behavioral therapy, and highly structured graded exercise regimens. Achieving true clinical efficacy in fibromyalgia management requires abandoning the search for a pharmacological magic bullet. Meaningful relief demands highly individualized, multimodal treatment strategies.